responsible for transplantation of CF patients in the Brussels University Hospital.
Short history of lung transplantation. This is Professor Hardy. He was the first to transplant a lung in a human in 1963. However, at that time point, we didn't have good immunosuppressants. We only had azathioprine and corticosteroids, and all patients who were transplanted died very quickly. And we had to wait until the years 80s, and this small vial changed everything. It was the discovery of cyclosporin A, which is a potent immunosuppressant, and this was the drug that made lung transplantation in humans possible, and this is Professor Shumway, who performed the first heart lung transplant at Stanford in 1981 in a patient with pulmonary vessel disease. And then shortly thereafter, also in our hospital and in France, combined heart lung transplantation began to be performed. And this was the first type of operations which were done because these were the simplest types of operation to be done at that time point. There are different types of lung transplantation. As I told you, heart lung transplantation was the first type which was performed for decades, but it's now abandoned. It's only done in patients who really have lung problems and complex heart problems, and then we go on with a heart lung transplantation, but it's really not done anymore. However, in the meantime, different other types of techniques were developed. Single lung transplantation, the transplantation of one lung, double lung transplantation, the transplantation of two lungs, and now also lobe transplantation, the transplantation of a single or two lobes. This is a slide from the International Registry for Heart and Lung Transplantation. They have a website, you can visit it. And it shows you over the years, from the early 1980s to now, the number of lung transplants which are performed worldwide. And you see in green the single lung transplants, and in blue the double lung transplants. And you can see that in 2011 about 4,000 transplants were performed worldwide. More bilateral lung transplants, more double lung transplants than single lung transplants. These are the indications for double lung transplants because cystic fibrosis is not the only indication. The main indication indeed is COPD or emphysema. And then we have cystic fibrosis here, and a third major indication which is on the rise is pulmonary fibrosis. And evidently single lung transplantation cannot be performed in cystic fibrosis because you have to extract the two infected lungs. If you did a single lung transplantation in a CF patient, you would put one normal lung in a patient and have another infected lung, and immediately the graft would be infected. So the standard operation for CF is double lung transplant. However, here you see the indications for single lung transplant, so one lung. Then there evidently it's mainly COPD and emphysema and pulmonary fibrosis. And there are some patients with CF who had a single lung transplant. These are patients who had a pneumonectomy for one reason or the other before lung transplantation, though they only have one lung left and this lung is replaced. But the standard operation for CF is bilateral lung transplant. Here you can see the proportion of indications for lung transplantation over the years. The main indication is COPD and emphysema in green, and another indication, as I told you, on the rise is pulmonary fibrosis. So these are the two major indications, and cystic fibrosis is here. There is a stable number of lung transplants which are performed for cystic fibrosis over the year, but it's not the main indication. So for whom would one consider lung transplantation? These are the general criteria for recipient selection. The patient should have end-stage respiratory disease, it should be symptomatic, progressive and irreversible. Preferably the patient should be ambulatory with potential for rehabilitation. he should be well informed, motivated and compliant, and he should have a reduced life expectancy. Indeed, still today, the primary goal of lung transplantation is not to have a better quality of life. It's really the only primary goal is to have a survival benefit. There are some absolute contraindications, but there are only a few left today. Cancer evidently is a contraindication to lung transplantation, except for some types of skin cancers. Active hepatitis B or C infection with histologically significant tissue damage is a contraindication, but as you probably maybe know, there are a number of drugs against hepatitis B and C that are in development, though probably this contraindication will also disappear. HIV is no longer absolute contraindication to transplantation. Evidently, active smoking, drug or alcohol use is a contraindication, as is severe mental illness, and if the patient is completely non-compliant, it has no sense to do a lung transplant. It's also difficult to do a lung transplant if there's no social network or support system. There are a number of relative contraindications, but they're not really so important. The first one is not so important for CF. Renal or hepatic insufficiency can be a contraindication, but then often in young CF patients, multiple transplantations are performed either at the same time point or in sequence. Obesity and malnutrition are a problem, and they should be corrected before lung transplantation. And there are a number of medical comorbidities we do not really have nowadays in CF that are also need to be addressed before transplantation. Pleurodesis, as I already told you, is a relative contraindication because evidently surgery will be more difficult. Mechanical ventilation was an absolute contraindication, but is no longer, and ECMO is also only a relative contraindication. For CF, what is important is that some centers refuse to transplant patients who harbor Burkholder Senocepacia complex, and Mycobacterium abscessus may also be a very big problem because it tends to infect the suture lines and tend to give pleural abscesses and pulmonary involvement after transplantation. It's a very difficult mycobacterium. Now, there have been some international guidelines for the selection of lung transplant recipients. The last edition was in 2006, but a new update will come out this year, and this lists the timing for referral in CF patients. When should you think about a lung transplant? That is when the FEV1 has fallen to 30%, I already said this before, or if you have a patient with advanced disease with rapidly falling FEV despite optimal therapy. So 30% is like a limit, but if you have 60%, then 50%, then 40%, you already should also think about lung transplantation, especially in patients who are female, in female patients, especially in those infected with difficult bugs, and especially in diabetic patients. So you should really think about it even before 30%. If the 6-minute walk test is below 400 meters, this is also an indication to refer. If the patient develops a pulmonary hypertension, or if there is a clinical decline characterized by increasing frequency of exacerbation associated with any of the below, which could be an episode of acute respiratory failure requiring non-invasive ventilation, increasing antibiotic resistance and poor clinical recovery from exacerbations, worsening nutritional status despite supplementation, pneumothorax or life-threatening hemoptysis despite bronchial embolization. These are the criteria when you should think and when you should refer for lung transplantation to a specialized center. And this is the timing of listing. When should a patient be put on a list? He should effectively be put on a list when there is chronic respiratory failure with hypoxemia, hypocarbia, if there is need for chronic non-invasive ventilation, if there's pulmonary hypertension, and if he is in functional class 4. Now, this is a slide from Eurotransplant. It englobes Hungary and Slovenia, I think, but otherwise it's Benelux, Germany, and Austria. And this shows the waiting times for elective transplantation. And you can see that the waiting times differ according to countries. In Austria, it's like 100 days, 150 days, 200 days. In the Netherlands, it's much higher. So it's like 1 year or 2 years waiting time for an elective lung transplantation. In Eurotransplant, the allocation rules is patient specific. That is, allocation is based on time weighted, on the blood group and size compatibility. There is at present no prioritization according to disease or medical urgency, and urgent organ request is strictly limited. In the US, they have developed over the last 5 years a lung allocation scores, which takes into account the medical urgency and the expected survival benefit. And this has been implemented in the US in order to give priority to fibrotic patients and to patients with pulmonary hypertension, and also to give some priority to CF patients in balance with all these emphysema patients who can be very ill but who often can wait a longer time. And this has had a positive impact. And this lung allocation score is not applicable in all Eurotransplant, but it's already applicable in Germany. Now, waiting list mortality, evidently these are the patients who die the most on the waiting list. These are the patients who have pulmonary fibrosis, and those who have pulmonary hypertension. Emphysema patients tend to die less on the waiting list, and CF is situated somewhere in between. There are some crucial time points for lung transplantation. There is a time for referral and assessment, where it is still too early to transplant the patient, where you just have to think about lung transplantation. Then you have patients who are already in the ICU on ECMO and so on. There it is probably too late. These patients are very sick and they will have an even higher surgical risk. And so, in theory, there is a transplant window where it is neither too early nor too late to transplant the patient. But this transplant window is really individually different. For some patients, it's very short. For others, it's very long. So this is just a theoretical explanation that there can be a time where it's already, again, too early, and another time where it's too late to transplant someone with success. 2 words about the surgical technique for double lung transplantation. The incision is either a clamshell incision, here as you can see it, and they open the chest like this, or 2 anterior thoracotomies without dissection of the sternum, and then they extract the lung and they implant the new lung, and they have to do the sutures of the bronchi, of the vena and the pulmonary artery. In some patients, preoperative assistance with an ECMO is necessary, but these patients can have higher surgical mortality and less good outcomes. And so at present, the line of thinking is that you can bridge patients with ECMO to lung transplantation, but during the bridging procedure, you should do everything to have your patient awake, mobilized, and improve him before sending him to the operating room. So the idea is not to put desperate patients on ECMO and then to operate on them, but to put patients on ECMO and then try to stabilize them and have them in a better shape for surgery. Now, once the lung transplantation is done, there are a number of complications, surgical and medical. Just a glimpse at the surgical complications. Evidently, CF is not so easy to operate on because of the chronic infection they have, like natural pleurodesis. These lungs are difficult to dissect and to extract. Normally it takes like 3 hours for one lung to be dissected and taken out before you can implant the new lung. And evidently, the more you dissect, the more you have a risk for hemorrhage. Another complication is if you have to dissect a lot, there can be lesions of the phrenic nerve, and the patients can have phrenic nerve palsy after transplantation. And other complications which are not CF specific are primary graft dysfunction, that is the grafted lung does this gas exchange normally, and you also can have anastomotic complication. I will show you an example. The most difficult part of the lung transplantation is the anastomosis of the bronchi, because as you will see a bit later on, the bronchial arterial circulation is cut and not re-established. So the bronchi of the donor have to live on very bad circulation, and the healing of this anastomosis is the most difficult, and sometimes this can lead to either dehiscence, that is you have here a lack, a hole in the bronchi, and evidently if you have infection, then you can have mediastinal infection, and the bacteria can migrate from the bronchi into the mediastinum or into the pleura. This is a very catastrophic complication. Anyhow, this is lung transplantation is major surgery, and the surgical mortality, according to the severity of the illness of the patient, is situated between 5 and 10%. And can be much higher if you have a patient on ECMO, and so it can be 30%. Now, this is for the surgical complication, but now our patient has survived surgery, everything has gone well, but afterwards he still is exposed to a number of medical complications, and these are listed here. First of all, acute rejection and chronic allograft dysfunction, and then evidently infections and cardiovascular and metabolic complications. Indeed, when you do a lung transplant, you take the lung from a donor, that donor, but there is no possibility at this time point to do any tissue compatibility. So normally, the lung transplant recipient will receive a good lung from a donor, but there is no tissue compatibility, everything is incompatible, and so the recipient's organism will mount a response for rejection immediately, because our immune system is programmed to reject everything which is foreign, bacteria, virus, moles, and fungi, but also foreign tissues. So this is in fact a normal reaction. And this is the reason why after lung transplantation, patients have to receive an immunosuppressive regimen. However, they have to receive a very high-dosed immunosuppressive regimen. And this is why I put the slide here. For the noble transplantations, the degree of immunosuppression after organ transplantation is not the same. If you transplant a liver is normally very well tolerated, and they just give some immunosuppressants, but not much. They stop the steroids and so. So this is an organ which only needs low immunosuppression. If you transplant a kidney or a heart, in a kidney and in a heart, there are not a lot of donor lymphocytes. A kidney is a kidney, and a heart is only muscle. So these organs have a moderate intermediate degree of risk for rejection, and so they only receive an intermediate immunosuppression compared to, for example, the lungs or the intestine. These organs are loaded with donor lymphocytes, and their potential for rejection is much higher as for the other organs. So lung transplant recipients will receive for lifetime a very important immunosuppressive regimen, normally combined by a combination of different drugs. And indeed, there are different phases. They first receive in most centers, or in many centers, an induction therapy with IV medication, and then they are maintained on a triple drug therapy combining calcineurin inhibitors like cyclosporin A or today tacrolimus, cell cycle inhibitors such as formerly azathioprine and now mycophenolate mofetil, and most of them receive steroids for lifetime. So this is really an important immunosuppressive regimen. Above that, they also may receive, if needed, treatment for acute rejection. So acute rejection is quite common because it's not possible, even with this important immunosuppression, to always have the optimal doses in the blood and in the lungs. And so we see on the transbronchial biopsies we do routinely after lung transplantation, we can see quite frequently signs of histological acute rejection. But acute rejection is not something which kills the patient. Acute rejection is treated with intravenous steroids, and if it's not too recurrent, too persistent, it may completely heal. The problem, the main medium and long-term problem after lung transplantation, once the surgery is done and there are no surgical complications, is the problem of chronic lung allograft dysfunction, which is expressed by bronchiolitis obliterans. That is, there is an obliterative process of the small bronchioles, and then the patient ends up again with respiratory insufficiency. This is an example. This should have been a bronchiole, and this is the wall, but you can see that there is no duct anymore, no air conducting anymore, and this bronchiole is completely obliterated, and evidently this patient cannot breathe. Even the lung parenchyma is normal here. Even with the normal lung parenchyma, this is a very important problem. And here you see it again at the higher, here's the bronchiole, it's completely obliterated, and here you see the normal grafted lung. So this is the main hindrance for long-term survival, this bronchiolitis obliterans syndrome. There are several risk factors which have been identified. Probably risk factors are acute rejection, especially if acute rejection is severe, persistent, or recurrent. Also, lymphocytic bronchitis or bronchiolitis is a risk factor, as is CMV pneumonia, or evidently incompliance. If the patient doesn't take his immunosuppressants, as I told you, these tissues are completely mismatched. He really is in line for chronic lung allograft dysfunction. There are other triggers for the syndrome, which are mainly infectious, like viral infection, or the combination of nodal donor and prolonged ischemic time, or gastroesophageal reflux disease. These incidents, these things can trigger inflammation within the lung graft and then trigger an acute or chronic rejection. This is a slide which shows that over time bronchiolitis obliterans syndrome is seen in a lot of patients. You have here the years after transplantation, up to 14 years, and you can see that 5 years after transplantation, 50% of the patients who have been transplanted will have developed this complication. This shows the relative incidence, the leading cause of death after transplantation. Evidently, in the early period after transplantation, you have a lot of infectious deaths, and then afterwards, as you can see here in red, the main cause of death is chronic lung allograft dysfunction in the form of bronchiolitis obliterans syndrome. Infections never goes away, but it's mainly this syndrome which is the cause of death and which is really the hindrance to very long-term survival after lung transplantation. We know from, it is known today, and I will not go into detail because we probably don't have the time, and it's a bit maybe too detailed, but we know with the immunosuppressants we give what to expect in terms of infectious complications. So we know when to expect bacterial infections, when to expect the viral infections, and when and how we have to consider fungal infections. Now, some CF specifics. CF is special because these patients are infected, and there has been a lot of debate in the early years of lung transplantation. Should these people be transplanted because they're infected, they're diabetic, they're malnourished? This is all over, and it is settled. Pseudomonas aeruginosa and even pan-resistant Pseudomonas aeruginosa doesn't change the success of lung transplantation. Aspergillus colonization does not change it either. There are some pan-resistant germs before transplantation that still remain a problem, such as Burkholder Cenocepacia, as I told you, Mycobacterium abscessus, and some of the pan-resistant fungi like Pseudosporum also remain a problem because they can disseminate under cover of the immunosuppression after transplantation. And then there's another CF specific which is very important. This shows you the peculiar anatomic situation of the transplanted lung. You have here the trachea of the recipient, and then the bronchi of the recipient, and here you have the bronchi of the donor. And as I told you, we section the bronchial artery circulation, and this is no longer really vascularized. And so, after transplantation, you always have, as you can see in this endoscopy, like necrosis at the point of the bronchial anastomosis, but it can get worse, and you can see that it can be very necrotic, and then evidently it can heal abnormally. With here you can see a stenosis of the anastomosis. And in CF, what is the problem is that evidently you have here the new lungs, but all this is still the nasopharynx, the pharynx, and the trachea is still colonized by CF pathogens. And evidently, if you have a bronchial anastomosis, as I just showed you, these pathogens can easily migrate again into the graft and infect an anastomosis or give rise to bronchitis and so forth. So that's a specific problem of CF. Else, in any case, after lung transplantation, only the lungs are replaced, and all the other CF-specific complications the patients already presented are still there. And on top of that, many of the patients will become diabetic because of the heavy immunosuppression. Tacrolimus and corticosteroids all are inducers of diabetes. And then, just to finish it up, word on cardiovascular and metabolic complications. Cyclosporin A and tacrolimus have important effects on the kidney. As you can see here, this is in rats. You have a normal glomerule, and then you have a rat who has received cyclosporin A, and you can see the vasoconstriction of this artery, which leads to the glomerule and this completely altered glomerule. And this is what we see in practice. Patients over the years will develop a number of morbidities. This is at 5 years after transplantation. As you can see, hypertension will be a problem. Treated hypertension will be a problem in 80% of patients. Renal dysfunction will be seen in like 55% of patients, and some of these patients will go on and have a renal transplant years after lung transplantation. Hyperlipemia will be a problem in about 2/3 of the patients. Diabetes, and this is for the whole transplant population, it's not only for the CF patients, will be 40% in the whole transplant population, but will be higher in a CF-specific population. And as I already told you, the bronchiolitis obliterans syndrome will affect a number of patients. So these immunosuppressants are necessary, but they will also cause by themselves toxic side effects and conditions that may need treatment after transplantation. This is the actual survival curve for all diagnoses after lung transplantation. Let's pick just COPD and emphysema in red. You can see that survival at 10 years for these patients is like 30%. And you can see in green the CF patients, and you can see that CF patients are doing better than the other ones, probably because the other patient populations are older and have more comorbidities. Also, evidently, the CF community and CF patients are much more aware about medical care, medical emergencies, and so forth. So there are multiple reasons, but in essence, they're doing slightly better than others. And at 10 years, you can expect a survival of about 50%. What is the function status of the surviving recipients? That is quite good, because as you can see, there are only very few patients that are not able to function autonomously 3 years after transplantation. So if surgery has gone well, if you don't have too much medical complications, you can have a quite good quality of life. So in conclusion, the surgical technique today is under control. However, what is very important is that still today, these patients have to receive an important and very high dose lifelong immunosuppressive treatment. And in spite of that, bronchiolitis obliterans syndrome, which is chronic alveolar dysfunction, which is chronic rejection, is the first cause of death medium term. And also infectious and metabolic complications have an impact on medium and long-term survival. A very scrupulous follow-up is mandatory. Actual survival is progressively improving, and some patients achieve a very good quality of life. However, saying this, important lifelong immunosuppression and a very important complication which is not under control for the, at present, makes me say this, that lung transplantation still is our last card to play, and it's certainly not a surgery we want to do for quality of life. We still have to do everything that a cystic fibrosis patient fares well with his medical treatment, and that he comes to lung transplantation at the latest possible moment. Thank you very much for your work.
Thank you. Any questions about transplantation? Everyone is too